Good morning, everyone, and thank you very much for inviting me here for to deliver this talk. I think our previous speaker, Dr. Oliver, gave a fantastic lecture integrating AI future technologies in medicine, and just wonder whether this may be a small bite size where we could actually apply this. So I'm going to speak about chemotherapy-induced thrombocytopenia. And we usually sort of describe it or define it when the platelet count falls below a lakh. And actually, that causes a lot of distress into the patients. They're worried if they're going to bleed. It delays chemotherapy. The problem with bleeding, if there are surgeries, then those have to be sorted out to give platelet transfusions. And then we think about dose reductions and so on. So it is a sort of a big problem which we need to deal with. And the reported incidence in various studies is about 5 to 15%. So how do we approach chemotherapy-induced thrombocytopenia? Being a hematologist, I do get referrals from my colleagues in the hospital. The first thing I look at is what is the underlying disease and is there any bone marrow metastasis or marrow disease. Typically, if there is pancytopenia, which would make me wonder whether there is a marrow disease underlying. I look at the PET scans to see if there is a lot of bony metastasis. Look at the blood film to see whether there's a leukoerythroblastic picture, which would make me say that yes, there is something going on in the bone marrow. So that is my first impression when I look at a patient. The second thing is associated ITP. We know in a lot of lymphomas, you can get an immune-mediated sort of an ITP picture. And then we look at the drugs to see whether some of these can actually help them, like steroids or rituximab and so on. So that's the other consideration I look at. The third is recent infections. A lot of these chemotherapy patients get infections. We know that bacterial infections can cause cytopenias. They can cause increased platelet destruction. You've got viral infections like EBV, CMV, which can cause thrombocytopenia. So again, checking for these markers becomes part of your panel in the initial evaluation. Any new medications? Have they received heparin? Maybe you're thinking of HIT. What about antibiotics, especially beta-lactams, which can actually cause antibodies, platelet-mediated antibodies, and cause thrombocytopenia? Any new additions? So whether we need to stop these medications or change them into something else. Recent transfusions, I think that is one thing which a lot of us probably miss. So back of the mind, it's rare, but platelet transfusion associated PTP, platelet transfusion purpura, where there are antibodies to the missing antigen on the platelet, HPA-1a usually, giving rise to thrombocytopenia and a purpuric rash. Coagulopathy, again, so thrombocytopenia, coagulopathy, low fibrinogen. A lot of the times when we ask for a coag screen, it is just the PT-INR, but it's important to the INR, APTT, and the Klaus fibrinogen, just to make sure that there's no sort of low-level DIC going on in the patient. The clinical history would also tell us whether they're feeling a bit sick, recent antibiotic use, low-grade fever, would just about say maybe they're in a low-level DIC. The next thing, again, rare but very important and causes significant morbidity is a microangiopathic picture. So a high LDH, a thrombocytopenia, schistocytes, fragments in the film, all these would point towards a thrombocytopenic microangiopathic picture, and in fact giving platelets in these patients is actually dangerous. So a lot of factors need to be evaluated in a patient as an individual patient. The next is the timing of the chemotherapy and radiotherapy. We know that certain chemotherapies typically take about a week for the platelet counts to drop, and then it can take another 4 or 5 days for the platelet counts to recover. So actually intervening in this sort of period may actually be counterintuitive. So just timing or wait and watch, or starting from a higher platelet count so that the platelet count doesn't drop too much, could be one of the strategies to be used. And as I talked about the type of the chemo, so typically platinums, anthracyclines, gemcitabine, taxanes, these usually cause a lot of cytopenias and thrombocytopenias. And then you've got the newer molecules, the targeted molecules, the TKIs, the immunotherapies like nivolumab. These also cause a lot of thrombocytopenias. So as the new molecules are evolving, the side effect profile is also getting more and more varied. So we need to keep an eye on all of these things. How the stem cell develops, the platelet develops, you've got the stem cell, then you've got the megakaryocyte CFC, the immature megakaryocyte, then the mature megakaryocyte shedding the platelets. Now the cyclophosphamide high dose will spare the stem cell, but the remaining of the cells will get destroyed. The busulfan, the melphalan alkylating agents will destroy the stem cell. Bortezomib will act much more later at platelet budding. So again, it depends upon what's the mechanism of thrombocytopenia. Now, there's a renewed interest in the TPOs, mainly because it has been always there before, but the resurgence of receptor agonists like L-trombopag and romiplastin have renewed the interest. Now, the mechanism of action is similar. The romiplastin and L-trombopag bind to the thrombopoietin receptor, activating the downstream phosphorylated JAK-STAT pathways, causing signal transduction and increased platelet production. Similar property with the L-trombopag, but usually it acts in the transmembrane domain of the receptor. Now, there have been studies looking at romiplastin. This is a small study, phase 2 trial, looking at sort of 40 patients. About 84% of the patients corrected the platelet counts within 3 weeks at a small dose of 2.5 micrograms per kilogram per week. Platelet count was titrated to reach 150. No adverse events on the marrow because there have been some concerns whether it caused fibrosis. But as with all TPO agonists, risk of pulmonary embolisms, DVTs is real. So this has to be taken with a pinch of salt. If there's high-risk disease like metastasis or colorectal or HCC, these patients tend to have a higher risk of thrombosis. There is a lot of studies in the literature. You've got low-dose L-trombopag starting from just 25 milligrams twice a week to higher doses. You've got romiplastin, which go up to 3 micrograms to 5 micrograms per week in patients with chemotherapy. Now, are there specific guidelines? To my knowledge, I don't think there are any formal guidelines, but please correct me if I'm wrong. But as a general guidance, either agent could be used to treat chemo-induced thrombocytopenia. The dose could vary from 25 to 100 milligrams. Romiplastin is typically 2 to 3 microgram per kilogram per week and is very easy to administer. In the Indian setting, probably romiplastin is better because it's cheap. It's probably about 30 pounds a week compared to about 140 pounds a week for L-trombopag. But cautions, because L-trombopag can interfere with food. It has to be taken on an empty stomach. We usually advise patients to take it on an empty stomach and nothing to be taken an hour later at least. Romiplastin can be given anytime. It's subcutaneous, but it's injectable and it's only once a week. I talked about thrombosis and interference of food. So these are two main factors to be taken into account. So I think I'm going to summarize by saying CIT can cause significant morbidity and interfere with delivering the therapy. This causes a lot of anxiety in the patient. The TPO receptors can be used, but with caution. There are no formal guidelines, but I know that I think the Italian group is due to present about 280 patients who've had chemotherapy and used TPO agonists. Similarly, there's a big US trial looking at using romiplastin in chemotherapy, and clearly larger studies are needed here. So with that, I think I will conclude my talk. Thank you.